unless I can plug in. Okay, upper motor neuron meets lower motor neuron, ventral horn. I'll try and draw it the same way that I had done previously, where we have this. This is the lateral. Oh, let's label this is the. Here you go. Transverse section through spinal cord. Okay, you've seen this before. Dorsal root ganglia over here. If we had to put in our lateral corticospinal tract, let's go ahead and draw that in right here. Remember the lateral corticospinal tract that we drew in before? So that's going to be the lateral corticospinal tract on the right side, and this is the lateral corticospinal tract on the left side. So label that as lateral corticospinal tract. Just to refresh your memory. And we also talked about this other tract up front here. That's the anterior corticospinal tract. That's the anterior corticospinal tract. Then we talked about over here. Oh, great! Thank you so much. Just plug me in. We'll label this. This is my ventral gray horn. Okay, and then this is my dorsal gray horn. Right there. Is that plugged in? Oh, you wonderful person. Thank you so much. All right. No, I don't have to worry. Okay, we can take our time. It's all good. The other thing, so in the ventral gray horn, is the place where our lower motor neuron cell bodies are going to live. Even though it's in the spinal cord proper, the lower motor neurons in the ventral gray horn are lower motor neurons. They're part of the peripheral nervous system, not the central nervous system. And there's something very special about the lower motor neurons. So I'm just going to draw 3 here up top. I'm just going to draw them on this side. So these are lower motor neuron cell bodies that exist in the ventral gray horn. Okay, I'm going to make it like a 6 on a domino. Okay, so there are 6 different lower motor neuron cell bodies. These lower motor neuron cell bodies exist in the ventral gray horn. These are all the players that we need to start looking at how the pathway finishes up. So you have this corticospinal tract. Remember, this is the lateral corticospinal tract travels through the lateral corticospinal tract coming from above. Picture that we just drew above. This travels through the lateral corticospinal. And this is the 90% that decussated at the level of the medulla. 90% that decussate at the level of the medulla travel through the lateral corticospinal tract down the spinal cord. And those other 10% that didn't decussate, they're coming down here also, but these travel through the anterior corticospinal tract. They haven't decussated yet. So axons traveling down the lateral corticospinal tract at their spinal level, at the appropriate spinal level, come out of the lateral corticospinal tract, and they're going to synapse with a lower motor neuron cell body. And that lower motor neuron cell body sends out axons that travel through the ventral root. Talked about that previously. Innervate skeletal muscles. Everybody see that? So nothing fancy. Everything's what we've done before, but just a whole lot more detail. You can see that upper motor neuron, those axons traveling down, the 90% that decussated, travel through this area known as the lateral corticospinal tract. These axons traveling together make this area, the lateral corticospinal tract. At the appropriate spinal level, they synapse with a lower motor neuron, and that innervates skeletal muscles. Okay, that's your lower motor neuron. Okay, what happens with the anterior corticospinal tract is here, when it reaches the appropriate spinal level, axons come out and decussate to the opposite side, and then synapse with their appropriate lower motor neuron. Okay, so both the anterior and lateral corticospinal tract axons decussate. Lateral corticospinal tract decussates at the level of the caudal medulla in the pyramids, medullary pyramids, and the anterior corticospinal tract decussates at its spinal level. It decussates in the spinal cord. Questions about that? That makes sense. Okay, that's pretty simple. Now, there's one more important point I need to make about the lower motor neurons in the spinal cord. In this ventral gray horn area, these lower motor neuron cell bodies, so I'll put lower motor neuron cell bodies, exist in a what's known as a somatotopic relationship with one another. We talked about a little bit about somatotopic representations when we talked about the homunculus previously, but you should know that in the ventral gray horn, lower motor neurons are also somatotopically arranged in the way that the body is presented, essentially. Yes, John?
What is the somatotopic relationship?
Going to show you in a minute. Good question. Great question. Okay, what's the somatotopic relationship in the ventral gray horn? The best, easiest way to remember it, if you think about upper extremities, okay, is Popeye. That's it. He's flexing his muscles, right? So what happens is that, so this is going to be, so there's an area that's equivalent over here. So on this side, if we just wanted to consider the right side of the body, the what is up top? Is it my flexors or my extensors if I'm Popeye? Flexors, right. So up top, anything that's up top and anything that's more dorsal, so I'll just say more dorsal, represents flexor musculature. So for example, there's one more thing. And if you're more ventral, you're going to be extensor. Okay. I think it's easier to see for upper extremities. I'll show you why here in a minute. And then if you're more medial, you're going to be proximal musculature, proximal muscles, going toward more lateral, and more lateral, you're going to be distal. Everybody see that? Does that make sense? I'll give you a minute to process. Go ahead, Ben.
Could you please just repeat what each of those cycles are real quick?
Mm-hmm. Yep. And I'll do it visually. So you have this thing here is represented here. Okay. So what muscle would this represent if this is here? What's an anterior shoulder? What's the shoulder flexor? Anterior delt. So here's my anterior delt, so we'll label that one. This one's going to be anterior delt. Okay? And then going down, next elbow flexor, biceps. Okay? And then at the level of the wrist, we can just say wrist flexor. Pick your favorite. There's a few. Okay, so topmost portion, or the lower motor neurons that exist more dorsally in the group, are going to be flexors. So then this is what you asked for. So these are going to be flexors if you're more dorsal. And if you're more medial, you're going to be a medial flexor, or a proximal flexor. So the proximal flexor for the shoulder is going to be anterior delt. Going down, elbow flexor is going to be next. That's going to be biceps. And then going down from there, it could be wrist flexors or finger flexors. Does that make sense to you now? Okay. Now, on the bottom, we have the same thing. We can say shoulder extensor. We can say posterior delt. Right. And then the one in the middle, if we had to say elbow extensor, it's going to be triceps. Okay, and then most distal could be wrist or finger extensor. Okay, so whoever asked about the somatotopic relationship, I don't remember who it was that's Johnny. Does that make sense now? That's the somatotopic relationship in the ventral great horn. Okay, so that's you good?
Yes.
Any other questions about that? Okay, so you should know that the ventral great horn has those alpha motor neurons arranged somatotopically. If those neurons exist more dorsally, they're going to be flexor muscles. They're going to be associated with flexor muscles. They're more ventral, extensor muscles. They're more medial, more proximal musculature, all the way out to the outside. Most lateral is going to be distal musculature. Okay, so two different things to worry about there. I like to use this because sometimes when you get down here, it lower sternum, when you think about it, doesn't make sense. Okay, because your hamstrings can be both hip extensors and knee flexors, so don't do that. Just stay here. Okay. All right. Moving on. That's upper motor neuron, lower motor neuron. Here. I talked about that, right?
Yeah, but it gets better.
Yeah.
Right. That's what I mean. So it'll go away eventually.
Okay, and now back to this great big overview. One more time, we're just going to look at, this is going to be your corticospinal tract overview. Super simple. Now that we've gone through all the details, this should just jump right out at you. So you've got this middle, okay, just here's my midline just to represent when things cross over. So I start here. And it's bilateral, so I'll start here on the right side. So I have an upper motor neuron here in the precentral gyrus. Okay, that upper motor neuron sends out an axon that travels down through the internal capsule, okay, through the midbrain, through the pons, to the level of the medulla. And again, I'll put in my little detail here. I've got my olive on the outside, and then I've got my pyramid on the inside, that little bump. At the level of the caudal medulla in the medullary pyramid, I'm going to decussate to the opposite side. Once I decussate, 90% are going to travel down through the corticospinal tract, the lateral corticospinal tract, and synapse with their appropriate lower motor neuron here, and head out and innervate skeletal muscles. And again, the corticospinal tract is under voluntary control. So cortex, cortical thinking. Okay, so this is your lower motor neuron. Remember, two neuron system. You have your upper motor neuron, and you have your lower motor neuron. And everything in between, all of this is and here traveling through the spinal cord, this is 90%, which is the majority. We're just going to talk about the lateral corticospinal tract. That's the big one as far as PTs are concerned. Samai, do you have a question?
Yeah, this might be a dumb question.
No, no such thing.
bilaterally because.
Correct. This is bilaterally. Absolutely. No, please ask me questions. I try and make it simple. This is happening on both sides. That's why I specifically drew this on the other side, so that everybody would realize it's happening from both sides. If I drew it in on both sides, it gets a little complicated. So I just try and keep it as simple as I can. Any other questions? Okay, so this is in the spinal cord, you're the lateral corticospinal tract, and up here, you're the corticospinal tract. Okay? Pretty simple, straightforward.
Is that also lateral spinal tract or just cortical spinal tract?
Up top, you're just the corticospinal tract. Remember, you become the lateral corticospinal tract. The only thing that becomes the lateral corticospinal is the 90% that decussated at the level of the medulla. That other 10% travels down the anterior corticospinal tract. So that's the differentiation. There's the anterior there, but the big one is going to be lateral corticospinal. That's the one I need you to get.
And that changes off at the caudal medulla.
After it decussates. So here, 90% decussate and travel down here. The other 10% just go straight down and then decussate at the level of the spinal cord. Okay, the big one as far as PTs are concerned is going to be your lateral corticospinal tract. Any other questions? Okay, moving on. Let's just talk about the brainstem descending tracts. I don't usually draw it in the big overview. Yeah, you need to know it. It's in there in the middle, but it's a small percentage. Okay. All right. This one's going to be your brainstem descending tracts, and these is what I'm going to represent here. Is just going to be the rubrospinal tract, the vestibulospinal tract, and the radiculospinal tract. A little bit more detail. Okay. And again, here's my representation of the brainstem. Okay, here's my midbrain. Here's my pons, and here's my medulla. And going down here, this is nothing more than just that transverse section through the spinal cord that we talked about before. Thinking about the tracts that we're going to use in the spinal cord, I'd like to go ahead and label those now. If you remember, so the lateral corticospinal tract exists right here. If you remember, right under the lateral corticospinal tract, we had this is the kind of maroon circle, I guess, if you want to, what I've been representing it as. That maroon circle, that's your rubrospinal tract. And most ventrally, there was another tract that we had labeled before that's going to be important here. This is going to be your vestibulospinal tract. Okay, it's in the anterior column, most ventral, vestibulospinal tract. And just above your vestibulospinal tract, the other one we talked about is your reticulospinal, and that's just dorsal to vestibulospinal here. So I've left out all the other tracks except the three that we're going to follow right now. Okay? Hopefully that's a little bit of a refresher. And the other thing that I'd like to add in here is going to be my lower motor neurons. And again, the lower motor neurons that are going to be most dorsal are going to represent flexor muscles. Pick your favorite. Most medial is going to be proximal flexors. Most distal is distal flexors. And then the lower motor neurons that are more ventral are going to be your extensors. Proximal extensors are going to be medial. Distal extensors are going to be more lateral. And I'm doing this bilaterally this time. Okay? And we'll label it as we go. Okay. Everybody caught up? Looking at the midbrain. Starting out here, we have this nucleus. In the midbrain, you have a nucleus that's known as the red nucleus. Again, to represent the decussation, I'm just going to put my midline in with my dots. Nothing different. When we looked at the overview of all those descending tracks, we noted that the red nucleus, axons coming out of the red nucleus, decussated at the level of the midbrain. They decussate immediately coming out of the red nucleus, and they travel all the way down. They travel caudally here through the spinal cord in the contralateral rubrospinal tract. So this is going to be the rubrospinal tract. Okay? You guys see that? And we talked specifically about axons coming through the rubrospinal tract. Does anyone remember what they innervate in humans? Elbow flexors, right. So let's go ahead and they come out of the rubrospinal tract at the level, and they're flexors, so they're going to synapse with middle flexor. Axons coming out of that lower motor neuron are going to come out and innervate elbow flexors or biceps. I guess there's others, but in general. Everybody got that? Okay. And again, for the purpose of simplicity, this would be at the level of elbow flexors, like C5, C6-ish. Okay, but I'm just going to put these other tracks that are going to on this same spinal cord level. So really, they'd be lower down than elbow flexors. They're postural extensors, or just extensor musculature in general. So we talked about this other nucleus here that exists in the pons. Okay, this is your vestibular nucleus. We saw that axons coming out of the vestibular nucleus travel down through the vestibulospinal tract. These axons do not decussate. They stay ipsilateral with their nucleus. Okay. Axons traveling in the vestibulospinal tract come out at the appropriate spinal level and are going to synapse. Specifically, here, I'm choosing to use proximal extensor muscles. So let's say this more proximal extensor, if we had to say lower extremity, let's say that's glute max, just to make it easy. Okay, so axons here are coming out to innervate, let's say glute max. So that's a lower, it's a big lower extremity extensor muscle. Okay, last track. Glute max.
It seems like that neuron that's going to glute max would ultimately go through the inferior gluteal nerve, don't you think?
Absolutely.
Just making sure they do.
Did you have a question, Paul?
It was extensor, right?
Extensor, yeah. This is glute max. So I'm down here, more ventral. These are extensor muscles. More ventral is going to be my flexor. So rubrospinal tract goes with my upper extremity flexor. The vestibulospinal tract is going to go with the lower extremity extensor. More proximal is going to be glute max. Okay? And the last tract to draw in there is going to be that diffuse body of nuclei in the medulla. This pink bunch of nuclei. Okay? And those nuclei are going to travel down ipsilaterally. Again, they do not decussate, and they travel through the reticulospinal tract. Okay. Axons coming out the appropriate spinal level are again going to synapse with extensor musculature. Okay, reticulospinal. So if you want to think, let's put it in the middle here, and we can say quads. Right? Knee extensors. And just all basic concepts. Okay, you should think rubrospinal, elbow flexion, reticulo and vestibulospinal extensors, extensor musculature, postural extensors. And that's it. That's the whole picture. 3 different rubrospinal tract, reticulospinal tract, vestibulospinal tract. Questions? And again, these are not under conscious control. Okay? All of these brainstem descending tracts, we'll even put something else in here. So remember the corticospinal tract is known as the pyramidal tract. That's because it's associated with the pyramids. That's where it decussates. These brainstem descending tracts are part of what's known as the extra pyramidal tracts. Okay, it's something you might see in the future. And if you see the word extrapyramidal, that's all that is. That's your pyramidal tract, voluntary movement, extrapyramidal tracts, not under your conscious control, but they're coming down to do something with muscles, but not voluntarily. Okay. Questions? Does that make sense? Felicia?
Up a little bit.
Push up. Mm-hmm. Is that good? You got your pyramidal and your extrapyramidal, and that's all your motor system. That's all she wrote. Now, next part's going to be something that we hit on pretty hard, because I know you need to know it. And then this is going to be upper motor neuron versus lower motor neuron lesions. So we're going to start out with upper motor neuron lesions. And this is super simple. Here I'm just representing the, it doesn't even have to be a cross section, just the outer portion of the cortical region. Midbrain, pons, medulla, there's your cerebellum. Here's a cross section through the spinal cord. Right. If we had to follow the upper motor neuron, we know that the upper motor neuronal cell body exists in the precentral gyrus, so I'll draw my upper motor neuron.
Go down.
Uh-huh. There's my upper motor neuron. Okay. So this is getting at, what does upper motor neuron lesion mean? Okay. So we know that upper motor neuron, I'm going to have here, not a lot of space, but my corticospinal tract, my lateral corticospinal tract, I'll just represent it here. Yeah, I'm getting there. Yep, this is our lateral corticospinal tract. Okay, and we also know that in the ventral great horn we have our lower motor neuron or alpha motor neuron that come out and innervate skeletal muscles. So this is your lower motor neuron. Okay. So path of the upper motor neuron, as we looked at in lots of detail, is to come Axons coming out of this upper motor neuronal cell body of the precentral gyrus travel through the midbrain, pons, cross over at the level of the medulla. You can't see it since it's sideways. And then they're just going to travel on down through the spinal cord in the lateral corticospinal tract. When they reach the appropriate spinal level, they're going to come out and synapse with their lower motor neuron. Nothing new. Just, again, the same thing that we've been looking at. Now the new part is going to be this. What is meant by an upper motor neuron lesion? Okay, that means that anywhere along this path of the red, whether it's the axon, the neuronal cell body, or the lateral corticospinal tract itself, that is considered an upper motor neuron lesion. So, upper motor neuron lesion. Okay. Anywhere, if there's damage, this person had a stroke, I mean, there's lots of different things, spinal cord injury, lots of different things that could happen. Okay, that would be an upper motor neuron lesion. So with an upper motor neuron lesion, you're going to have a characteristic clinical presentation. So let's say in the beginning, right after the lesion, say first 2 weeks, approximately, and then later it'll progress, or it may progress to something else. Okay, in the beginning, right when the person's had a stroke or spinal cord injury, you're going to have paralysis or paresis. So paralysis is complete absence of movement. Paresis is lack of movement or lack of strength. Okay. In the beginning, you're also going to have hypotonia or low muscle tone. Okay. And you're also going to have hyporeflexia. That means lower than normal reflexes. Okay, and that's immediately after the injury.
What was it again? Hypo something.
Hypotonia, T-O-N-I-A, and hyporeflexia. So one, hypotonia, is nothing more than reduced muscle tone, and hyporeflexia is nothing more than lower than normal reflexes, and we'll learn what that means in a little bit. How you can actually grade somebody's tone and grade their reflex activity. But as time goes on, patient might still present with paralysis and paresis. However, I'll put this in red, the hypotonia after 2 or 3 weeks can progress to hypertonia. In other words, high muscle tone. And sometimes if you see somebody walking around with a stroke, if their arm is like this or their leg is like this would be high muscle tone. Okay, that's hypertonia. Different kinds, we'll worry about it next year. They can also present with hyper, H-Y-P-E-R, reflexia. Okay, what this means is that if you have a clinical presentation or you're working with a patient that has hypertonia or hyperreflexia, you knew that is due to an upper motor neuron lesion. Flat out. That's it. Those two, hypertonia, hyperreflexia, go with an upper motor neuron lesion. Never a lower motor neuron lesion. Those things will tell you that it's an upper motor neuron lesion. Does that make sense? Okay. If you're stuck here in the beginning, you're going to see this is very similar to the next presentation, but there's something there that we'll look for too. I need you to remember that hypertonia, hyperreflexia goes specifically with an upper motor neuron lesion. Those are signs and symptoms that are characteristic. Not every person with an upper motor neuron lesion will progress to hypertonia or hyperreflexia. Clinical presentation, about 25, depends on who you read, 25 to 50% of individuals with an upper motor neuron lesion will actually progress to there. They could just remain here. But if you see this, you know it's an upper motor neuron lesion. Got it? Okay, moving on. Almost done. Let's look at lower motor neuron presentation. Same thing we talked about. Same drawing, no difference. Now we're just going to focus in on the lower motor neuron signs and symptoms. So we know that, if I want to draw in here's my lateral corticospinal tract. Okay, here's my lower motor neuron cell body that exists in the ventral gray horn. Comes out and innervates my skeletal muscles. We know that the upper motor neuron cell body exists here in the precentral gyrus. Comes on down, travels through the internal capsule, through the midbrain, through the pons, crosses over in the medulla, comes out, travels through the lateral corticospinal tract, and innervates here. A lower motor neuron lesion is anywhere from the neuronal cell body through the axon. These would be lower motor neuron lesions. Okay, so upper motor neuron still intact. There's no change there. Absolutely nothing. Everything that you see is here at the level of the lower motor neuron only. Okay. So what you see with a lower motor neuron injury could be size. So here's clinical presentation. Okay, you're going to get paralysis or paresis. Okay, same as before. You might get hypotonia. Okay, you might get hyporeflexia. So far it looks just like the beginning of the upper motor neuron lesion. The last two are going to be specific for the lower motor neuron lesion. And I'll write it in green. And these are going to be two words. When you see these words, your brain should say lower motor neuron injury. Okay? This is atrophy and fasciculations. We'll see a video of fasciculations later in the semester when we look at cranial nerves. I have a nice video that shows what it is. What's the difference between atrophy and hypotonia? Does anyone know what that difference would be?
Atrophy, whenever muscles go down, the cell size itself goes down?
Yeah, so the actual size of the muscle will shrink. You'll see a wasting away of the muscle if it's atrophy. Okay, hypotonia is nothing more than reduced muscle tone, and you can feel hypotonia when you take somebody through passive range of motion. I understand you're just now starting passive range of motion in foundations, right? So when you move an arm, you can tell whether or not there's any muscle tone behind it. Hypotonia would be a reduced tone. More than that, yes.
So is the uniqueness for upper motor neuron lesions, is that the hyper or is that the change in hypotonia?
Uniqueness is so it's not so hyperreflexia and hypertonia are always associated with an upper motor neuron lesion. Atrophy and fasciculations are always associated with a lower motor neuron. They never cross.
Okay.
Other questions? Okay. So the last one's super simple. We're going to talk about, these are just reflexes. This is a stick man. Just looking at stick man. When you're grading reflexes, that reflexes have a grade associated with them. And reflexes, if you grade it 2+, that means the reflex is normal. Okay, so you need to know that a 2+ reflex is normal. A 1+ reflex is hyporeflexia. A 0 reflex is areflexia. Anything greater than 2 plus is going to be hyperreflexia. And we'll see this again in a minute in lab. Okay, so simple scale. If you see a 2 plus reflex, that's normal. A lot of times when you're representing reflexes, it's represented on this stickman figure. And this area here is the reflex for triceps. Does anybody know the spinal nerve level for triceps? C7. Okay. Then this area here represents biceps. And that's C5, C6. This area here is brachioradialis. Again, that's going to be C6. This is patellar reflex. It's going to be L3, L4. And then your Achilles reflex, S1. So this is, I've just labeled all this, but when you look at it, if you're looking into a patient's chart and they're documenting reflexes, what you'll see is literally the stage of the reflex or the grade of the reflex. So for example, you'll see something that says 2 plus here if the triceps were normal. You'll see 2 plus here if the biceps were normal. You'll see 2 plus here, brachioradialis is normal. You'll see 2 plus here if patellar reflex is normal. And you'll see 2 plus here if Achilles reflex is normal. Okay, so you should know just by looking at the diagram what reflex is. Sydney?
So they give it to you with a diagram, not like written.
That's correct. You'll see this picture. But the only thing you're going to see is that 2 plus. So, and they might document that there's hyperreflexive, so you'll see a 3 plus instead of a 2 plus. Or areflexive, you'll see a 0. But you should know the relative positions of what you're going to see. Questions, Ben?
For hyperreflexive, you ever see anything more than 3 plus, or is that just the standard for it?
So 3 plus, so the highest reflex in, there's something called clonus. We'll look at a chart when we get to lab, and that's 4 plus. So if somebody demonstrates clonus, and clonus is nothing more than you'll learn how to test it next year, but I'm going to show you this year. So you just take the wrist and snap it back, and if they had clonus, it would be vibrating like that. Or you can do the same thing with ankle dorsiflexion. So you snap somebody in ankle dorsiflexion and their foot wavers like that. That's called clonus. That's considered a 4 plus reflex. And you can see it's got to be that quick snap, same as all the other reflexes. You're stretching the tendon. And with clonus, you just have that repetitive motion. Okay? And we'll see a chart here when we do the lab activity. Other questions? Okay. Let's go ahead and